Hi, everybody. So, my name is Princess. I am in Team A, and our focus for this week is diabetes type 1 and 2. On this first page is just an introductory for the class, for my name, and actually the topic that I am going to be presenting on today. For the next slide, I'm also gonna apologize because I'm also shooting a video for the YouTube page. So if I keep going back and forth, I really apologize. For this page, its focus is on the introduction of diabetes type 1 and 2. Because of time, I am not gonna read everything. However, I am going to summarize as much as possible that I could. For diabetes itself, we also have to think about what it is. Diabetes mellitus refers to a group of disease that affects the way our body processes sugar. It is caused by a deficit of insulin secretion from the beta cell or by lack of response by the cell to insulin. So, in a summary of that, it can happen for two reasons: that there is not enough insulin that is being produced, or that there is enough that it's produced, but our body is resistant to using it. Now we have to then think about the different type of diabetes itself. There's type 1, as you can see on the whole thing. There's also type 2. There's also pre-diabetic diabetes, and there's also gestational diabetes. We're going to be focusing on diabetes type 1 and 2 and the management of it and the complications of it also, and also the signs and symptoms that we often come across. There are some common signs and symptoms. Often, diabetic patients will complain about being hungry, being fatigued, having to have excessive amount of tasting, or complaining of urinary frequency, or dry mouth, or itchy skin, or blood vision. Often, those are usually the common symptoms that you will see. For type 2, though, specifically, patient will complain about weight gain or increased abdominal gut. So a lot of times their abdomen, when you measure it, the abdominal gut, there's an increase with it. Um, and the longer it progresses, a lot of times you will hear patients often that have DKA, which we are going to talk about. It's one complication of diabetes itself. They will complain about polydipsia, polyphagia. And when I was in nursing school, we usually talk about the three P's. So those, when I was in nursing school, starting from RN. Now I'm still in nursing school, which is so funny. But we're gonna move on to the next page. On the next slide, it basically just gives us an overview of the pathophysiology of what type 1 and type 2 diabetes is. I'm going to skip past this because there's another slide that basically, I love this slide because it basically focus on the group of people that are more predominantly at risk for being type 1 and type 2. For type 1, age itself, children and younger adults are more at risk for that. For type 2, older adults and some younger adults are more at risk for it. And then it talks about the onset of it. For type 1, the onset is usually very acute. For type 2, it's insidious, it's chronic. It's not something that just happened. And then for type 1, it talks about what predominantly causes this, or what's the cause of it. Type 1 is an autoimmune destruction of either the beta cell not working, or a family history of it. And type 2, they always say, hey, lifestyle modification. And this is basically type 2. And I always tell my patient, you'll be surprised how much of a little exercise can help with with managing diabetes itself, or how much of diet control, if you could remember to eat a lot of greens, and less amount of every other thing. Even fruits itself, you have to be careful with how much fruit you're eating, because there's also sugar, amount of sugar. Fruit itself has sugar itself, so you got to be careful with that. Type 2 also talks about environmental factor, weight itself, obesity, and our lifestyle, how that can predominantly make one to be pre-diabetic or to be diabetic itself. And on the next slide, I am so sorry. The slide, we're gonna go back on that slide. Let's see. Or we can just I think the other slide is just a repetition of what I've just said. We can just furthermore talk about this one. For this slide, we have basically say list 3 complications of diabetes itself, describe the pathophysiology of each one of them, and explain the preventative measure. I picked DKA, hypoglycemia, and hypoosmolar, hyperosmolar, hyperglycemic, not ketotic coma to talk about. For DKA, a lot of times infections usually predominate patients to having to go into a DKA. Typically, their blood sugar is high. You're talking about greater than 350. You're talking about 400 upward too. For hypoglycemia, the problem is that it's too much insulin that lowers the patient's blood sugar. So their blood sugar is low. So a lot of times patient will be very shaky. And they typically will know. They'll tell you, I think I need an orange juice. I think I need something. I feel like my blood sugar is very low. I've had patient comes and tell me, hey, I feel like my blood sugar is very low. I need to take something. I'll go to in the hospital, or do I work in cardiac? I go to is we don't do orange juice because cardiac patients, they want you to do orange juice. They want you to do anything that has sugar itself. If the patient can eat orally, they can take anything in, do anything that has sugar with it. Orange juice, cranberry juice, but working in cardiac, we do cranberry juice because some cardiac patient has end-stage renal, and end-stage renal, you don't want to do orange juice with them. That's one aspect that you might not know that you should know by now. So typically, and if patients cannot do oral or cannot take anything in, you want to do something intravenously and just pop in that sugar. They need the sugar. That's basically what I always tell. You need the sugar. We're just going to get you the sugar whatever way we can, whether it's by mouth or whether it's by any other means. Hypoglycemia is really, 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 can be really, again, detrimental, life-threatening. I have had patients that have gone into really severe low blood sugar, and it's not something that you can, you want to see. I always say, hey, it's better for you to have gas in your car, and it's a lot of gas because it's still going to be moving, than for you to not have any gas in your car because it's not going to be moving. And that's basically what hypoglycemia is. You ain't got no gas and it's not going to move. So you got to do everything to make sure that there is gas. Let's see. HHNC. Basically, this typically happens with type 2 patients. And again, infection usually predominate patients to go into this. A lot of times their blood sugar is very, very high. You're talking about 600 up, so they have to manage this. We're going to go on the next slide. And on the next slide, it talks about A1C. And the question is, explain what hemoglobin A1C is and what it measures and how it's important to the management of diabetes. You go to the hospital, and when they do blood work, they usually will take the patient A1C. They want this to be lower than 6.5. They want it to actually be lower than 6. If it can be lower than 6, that's awesome. When it's higher than 6, you are pre-diabetic, and when it's above 7, you are definitely at risk for being diabetic. A lot of times too, patient comes in admitted for one thing only to find out that their blood sugar is skyrocketingly high. Again, their blood sugar could also be high for multiple reasons, such as infection. It could also be high if they were on steroid itself too. That would predominate their blood sugar to go really up. So this is where you have to figure out, hey, is it that they're diabetic, or is it that complications or the illness or the disease that they arrive with skyrocket their blood sugar and made it very high. But typically that's what they will use. And A1C is, I will just read off the slide. It's used to monitor a long-time control of diabetes, 8 to 12 weeks of blood glucose level. It's typically done every 3 months. And like I said, they want it to be lower than 6. Lower than 7, but lower than 6. So we're going to go, remember that, lower than 6. So we're going to go on the last one. There are also other things that they would do at the hospital itself. They would do regular blood sugar checks too, depending on what it is. This slide, I am so sorry. I don't even know how to like put it back up. Let's see. We'll go back on that. Yes, but this is just basically an emergency treatment for hypoglycemia shock. When we talked about hypoglycemia, typically at the hospital, every hospital is different, but they don't want it to be lower than 70. Typically 70 to 100 is what they're looking for your blood sugar level. When it's lower than 70, there's a question. Oh my gosh, you got to get the patient's blood sugar to go back up. But if you're ever in a situation that your blood sugar is very, very low, if the patient is conscious, like I said, give the patient sweet fruit juice, honey, candy, anything with sugar on it. I always tell people anything with sugar on it. But again, like I said, I work in cardiac, so you still have to put other things with patients, in mind. Like you can't just give orange juice because end stage renal, but you can do cranberry because cranberry has a lot of sugar. And if the patient is unconscious and you cannot give anything, you can always do 50% of glucose intravenously, and you just pop that thing in and it works. And if it doesn't, you do another one again. And for diabetic ketoacidosis or diabetic coma or hyperglycemia, the emergency treatment is insulin, fluid, and bicarbs, sodium bicarbs. And typically those insulin fluid given intravenously, sodium bicarbs, same thing. But you want to know, again, what's the cost, what's costing this. So that's a very important thing to keep in mind. We are going to go into the next slide. I'm trying to, because I have to keep this video 10 to 12 minutes short. On this slide, you see diabetic foot ulcer. I wanted to put that in just for everybody to see what happened when improper management. I'm just basically going to read off the slide because I really love that. It's a summary of it. It said there are multiple issues that could go on if diabetes itself is poorly controlled. We are familiar with what's called peripheral neuropathy. Basically, patient will complain about numbness and tingling and weakness and muscle wasting. Sometimes you see ischemia, like this patient's foot itself. You see a lot of just ischemia around it, like a lot of necrosis around that, all dark and eschar and all of that. And you could tell that the patient just did not take care of it, because now that's a problem, because it's just, there is not enough. It's all necrotic cells, the tissues, and basically it's, and I mean, with diabetic patients, a lot of times they have low sensations. Like I said, they cannot feel. So even when they put their legs on hot things, they can't. So there are a lot of teachings that patients should have. Mostly this is new to them. Lots and lots of teaching that they should have with them before you either discharge the patients or send them home to their family and stuff like that. He also talks about how diabetic patients too are also at risk for amputation if they're not properly controlled. So the question and the things to keep in mind is, how do we teach our patients to control their diabetes itself, to control the disease? Now, luckily, they have a lot of things that patients could use to test their blood sugar at home. They have a lot of things, insulin pump that could administer the insulin itself or calculate how much calories that they're taking. There's so many technology that has advanced to a point that our patients can actually do a lot of diabetic management themselves, but we have to make it very available for them. We have to teach them how to do it because there's a lot of complications that goes with, imagine losing one's foot. I've had patients that have had their limbs just amputated because they just did not take care of their foot itself. If you guys have any questions, you can always just put it down and let me know. And if I see it, I will reply back. And I hope this PowerPoint, I hope I didn't talk too much, 1 and 2. I know some slides were very funky for you guys to see. I will go back and fix those slides to make it easier for you guys to read it. But until then, I am timed on this. This is approximately 15 minutes now. So thank you so much. If you have any question, put it down. Thank you.